Good afternoon, everybody. It's nice to be here. Thanks, Will, for that nice introduction. I'm going to talk to you today with two hats on. One is as a senior advisor and part-time employee of the American Academy of Family Physicians for now over a decade, and a newer position that I've just taken on primarily as a volunteer at this point, as the president and CEO of a new organization, nonprofit called Direct Trust, that I'll be talking with you about this afternoon. So here's what I'd like to do in the next 15 to 20 minutes, fairly quickly. You do not have my presentation, but I will be giving it to the Redwood MedNet folks, and they will have it available for you, I'm sure, from their website. I'm going to talk a little bit about the brief history of and background of directtrust.org and how it came into being and what we're trying to accomplish. I'm going to talk about some of the participants, the missions and goals, and then a very brief review of some of the work done to date. Then I want to talk a little bit about what we plan to be doing in the near future to support many of your efforts and many of your direct implementations. And then hopefully we'll have a good round of questions. Some of this information may be very new to you, and that's okay. I will try to provide you with pointers and places to learn more. And I'm here today, tonight, and all day tomorrow. So this is basically the timeline for directtrust.org. What happened, as many of you may know, is that in April of 2011, ONC held a boot camp for Direct and invited almost all of the HIEs. I think they probably invited everybody, but I think 47 of them showed up. And it was great. It was a real kickoff to the Direct project. ONC basically said, go forth and do really good things with Direct. And having been one of the people who was in the Direct project from the very first, I was excited about that. One of the things that I did, though, being somewhat curious and a little stubborn as a person, was say, well, okay, now we have the technology and the specifications and the protocols, and we know we need to use a public key infrastructure, PKI, and digital certificates so that subscribers of one HISP can communicate with subscribers of other HISPs, kind of in the same way that your email works. How is that going to work? And Sean Nolan was one of the people who I asked the question, and there were maybe 5 or 6 others, David McCauley at Cerner, Wes Rischel, Don Jorgensen at Impriva, and sort of everybody had a slightly different answer. How is one health internet service provider going to know how to trust the digital certificates of another health internet service provider without having to form a contract between the two, which would clearly not work? And so out of those discussions was born this Direct project work group called the Rules of the Road work group. And the basic assumption there was that, boy, we need some rules of the road so that the trust fabric, the security and trust fabric, can be built, and we can automate, if you will, the ways in which these health internet service providers can trust one another. And it was sort of the undone work. There are some other parts of Direct that are sort of undone, like edge client interfaces with HISP, but this was the real biggie in the room. And over the next few months, we did a number of things. One, kind of in line with the duocracy of the Direct project, we didn't just talk about things, we started to build stuff. And the thing that we built was a certificate policy, an X.509 certificate policy, which guides policy and practices around the identity verification necessary to issue digital certificates and the manner in which digital certificates can be issued and revoked and managed. That took us to roughly October of this past year, in which the group decided, gosh, we've got 50 or 60 members by this time. We really ought to split off away from Direct, as hard as that was to break that bond, and create a separate nonprofit organization which would be responsible for continuing to build the security and trust framework that would support Direct implementations around the country. And we formed a collaboratory relationship with the Rhode Island Quality Institute and their efforts to create a state trust community, which have been very successful. We are in the process now of developing an accreditation program for HISPs, certificate authorities, and registration authorities in association with ENAC. And we have grown to almost 200 companies in the wiki. And I'll talk a little bit more about that accreditation program later. I know you can't read this, but when you have the handout later, it may make sense to you. There's some trends and things which you probably want to look at very closely. We owe this to our friend Will Ross here. And I've shown this cartoon to a lot of people. And they say, oh, that's what you're trying to do. If you remember, the original of this cartoon was, when you're on the internet, no one knows you're a dog. And now it reads, before directtrust.org, no one knew I was a dog. The important issue here being that if we're going to have a security and trust framework that supports direct implementation, it really sort of starts with identity and identity verification, because that's linked in turn to the digital certificates and the trust associated with those digital certificates, which is then in turn linked to the ability to validate the sender and receiver of direct, as well as to encrypt the messages. And if any of that falls through, direct is not going to work. Or at the very least, we will have repudiations of messages and all sorts of problems. So who is directtrust.org? These are the companies who are on the current board of directors. Directtrust.org was incorporated as a nonprofit healthcare alliance dedicated to supporting direct in April of this year. And I think you can see that very much like the wiki membership, it represents a very broad swath of stakeholders in direct, including certificate authorities like DigiCert and Safe Biopharma, HIEs like Rhode Island Quality Institute and Gorge Connect up in Oregon, an EHR company like Cerner, interestingly, a very large chain pharmacy like Walgreens that has begun to implement direct, and a health education company that everybody knows, HealthWise, and then a few people like the American Academy of Family Physicians. Now, why would the American Academy of Family Physicians be interested in something sort of esoteric and down in the weeds like an organization like directtrust.org? And the answer has really been explained to you with John Blair's talk the last hour. We have, among our membership in the American Academy of Family Physicians, 70% of our members using electronic health records now. Not a single member, one of those users, can communicate with another user of a different vendor. So we still have Allscripts folks being unable to communicate with folks who use EMDs, unable to communicate with folks who use Epic, and so forth and so on. And we really want to push this ball over the goal line in the next couple of years. We want to make it possible for any provider in any practice using any technology to be able to communicate to anyone else and not be stumbling over the proprietary technology. The same thing is very true with patient engagement. We want our providers to be able to communicate with patients, and we want patients to be able to communicate with providers, and we want that to be easy, like email, ubiquitous, worry-free, but also secure. Our web presence has been a wiki, directtrust.wikispaces.org, .com. You're all welcome to join this wiki. This is where most of the intellectual property, the work groups meet. Again, that's directtrust.wikispaces.com. We do have a new website being aboard. It's not ready for prime time yet, don't go there. It's directtrust.org, but you won't see very much until we get up and running in the next couple months. So, I've mentioned that The organization was formed as a nonprofit, multi-participant stakeholder alliance. We are focused entirely on supporting the security and trust framework for direct and directed exchange. I'm often asked, why is this so important? And I say, because otherwise directed exchange will not grow at scale. It will not be able to be adopted and implemented quickly. Most of the HISPs right now are one HISP, and they are serving their subscribers and are just confronting the problem of, oops, what if somebody from another HISP knocks on the door, and how do I make sure that that can happen? We have a number of documents that are valuable and already being used in this field, the most prominent being the X.509 certificate policy, widely used now to align the registration authorities and certificate authorities, issuance and management of digital certificates. And we're delighted for you to, in your programs, reference that certificate policy if you would like to. We are also in deep discussions, we haven't quite finalized them, with ENAC, the Electronic Health Care Accreditation Commission, which does a lot of accreditation, to accredit HISPs, certificate authorities, and registration authorities, and recognize those who pass that accreditation in a manner that then allows them to more easily know who is trustworthy and for them to be recognized as trustworthy. We will probably, as a subsequent act, begin to distribute trusted anchor bundles as a function of that community evolving and recognizing the need for an entity to do that. I should say that all of this is being done with great respect for the evolving rulemaking being done by ONC and CMS with respect to the UNWIN governance, and then we will be we are committed to being aligned with them. But a number of health information exchanges around this country have said, look, we don't want to develop our own program for accreditation. Each of us now is putting a significant amount of money and energy into doing that. I think it was important that Rhode Island Quality Institute did that. I think it was a really good job by Pennsylvania. But for more states to put more efforts into a state or regional evaluation program like this doesn't make sense. We think that it makes a lot more sense to do it on a national scale and therefore allow the state agent entities to go about their business and make their HISP marketplaces work by participating and doing stuff that they need to do at the local level. Some of you are familiar, I'm sure, with the duties of a health internet service provider or sometimes health information service provider. And I have this slide just to make clear that some of these functions are pretty straightforward and are a lot like an internet service provider providing services for internet connectivity and mail. So for example, one of the duties of a HISP is to provide subscribers with an account and to provide them with direct addresses. So I have a couple direct addresses. One is dkibbemd@surescripts.direct.net. A HISP would also provide the web portal and increasingly, I think importantly, the EHR or personal health record integration, which is essentially becomes the clinical messaging application inside the EHR. We've learned that physicians and providers, organizations really don't want to use web portals that take them away from their electronic health record in order to do clinical messaging with direct. I think that makes a lot of sense. In the recent weeks, we have seen several electronic health record companies, NextGen among them, for example, stand up and say, we're going to be direct compliant. We are not going to become HISPs. We will allow the customers of ours to choose the HISP that they want. Now, most people don't know very much about the other functionality that I'm going to talk about briefly here, which is that the HISP will be responsible for identity verification for the individuals and organizations that are participants in direct. And that is a function of a registration authority. They'll also be responsible for arranging for digital certificate issuance and the management of those digital certificates. And that's a certificate authority function. And then Altogether, these folks need to maintain the integrity of trust and security and its framework, and we see that as DirectTrust.org's primary responsibility, as well as the function of staying current with federal policies and regulations. Many of the members of DirectTrust.org are there at the meetings in order to stay current and to understand about the evolving regulatory environment for Direct. Some of you may be aware that just this week a number of guidelines were released by ONC that are pertinent to this discussion. So these functions here are really just about email, basically, and very straightforward, and use off-the-shelf protocols and specifications for email, basically SMIME over SMTP. These functions are functions of security and trust, and they have to go hand in hand, or Direct isn't going to work. This looks like a fairly complicated slide, but really all it does is show you the various roles and responsibilities of HISPs, registration authorities, and certificate authorities in the operation of serving the needs of a subscriber, whether that's a provider or a patient, for the benefits of secure email using Direct and its protocols. And I would encourage you, if you haven't already seen a slide like this, to look at it fairly carefully at some point. Registration authorities and certificate authorities can be the same body, but they can be different. In Rhode Island, for example, the registration authority is the Rhode Island Trust Community, and they are essentially hiring a certificate authority to issue the certificates after the registration authority has performed its function of doing the identity verification of the provider organization and at least one member of the provider organization. Certificate authorities have a whole set of activities that they need to perform, and they need to base that performance on that first step of individual identity verification, which of course at some point needs to be repeated in the same way that we have to have our identity verified for the state licensure and so forth. And then the health internet service provider, in most cases, is the entity that packages those services so that the subscriber, with relative ease, can get what he or she wants to get, which is the ability to communicate with other people who have other organizations that have direct addresses. There's, of course, some technology involved, but one of the points I want to make about this is that when you really look at how these different components of the Direct project and what is now being called Directed Exchange, according to the Direct standard, there is a series of quite important relationships between them. And those relationships have to be codified with respect to policies and practices, and those practices need to be audited, and hence the need for an accreditation program and an ongoing audit to assure that these practices are being in play by the various participants. Now, that all may sound kind of complicated to you. I can assure you that other industries, aerospace, biopharma, the federal agencies, all do this same thing in order to participate in secure exchange of information and access management. I can also assure you, give you an example of what this is like when it doesn't work. So not too long ago, I was talking to a HISP that was communicating with another HISP. In other words, the subscribers were actually doing the sort of complex dance with the digital certificates that allows Direct to work. And my question was, well, okay, how do you know to trust the HISP that you're communicating with? I mean, you're a trust agent for your subscribers. That HISP is a trust agent for its subscribers. How do you know that they're trustworthy? And they said, well, we just know them. They're good guys, right? And when they checked, that other HISP had never had a security audit of any kind. There was no third-party verification that they were abiding by HIPAA. They were using certificates that were essentially made up. And as a physician who would potentially be one of the subscribers of either one of those HISPs, my reaction was, good God, you think I'm going to participate in a program like that? You know, I'm going to send my patients protected health information through that system? I mean, the liability is huge. And I don't want to be critical of those particular participants because they were basically in pilot mode and so forth. But you get the idea. If the subscribers to a HISP participating in direct are not really assured with respect to the security, privacy, and trust with the exchange of that information, then the whole process of direct will break down and fail. And that's what we don't want to happen. We want to make sure that it succeeds because, as you've been told, and I think many of you probably firmly believe, directed exchange can be a tremendous asset in terms of offering care coordination, improvement in quality, and lowering the cost of care. So this is my final slide, and I just want to explain to you how this works. Many of you are aware that Rhode Island has set up a trust community, and those of us in directtrust.org and the folks who were in the Rules of the Road work group were helping them do this from the very beginning. I describe that as kind of a collaboratory experiment. We were helping develop some of the policies that they were putting into place. They were putting them into place. And the cool thing is that it works. Rhode Island has chosen to evaluate health internet service providers independently. There's an evaluation criteria, most of which were developed within the directtrust.org work groups. If those health internet service providers pass, then they are allowed to be part of the health internet service provider or HISP marketplace in Rhode Island. The Rhode Island RICI is acting as the registration authority. So if there's a provider or medical practice that wishes to participate in direct, they do their identity verification through Rhode Island Quality Institute. The Rhode Island Quality Institute then passes that information on to the certificate authority, which in this case is DigiCert. And DigiCert uses that information to issue what is a medium level under FBCA digital certificate or a NIST level 3 digital certificate, which is a fairly high grade, high assurance certificate, referencing both the Federal Bridge Certificate Authority's certificate policy and the directtrust.org certificate policy. I'm getting kind of down in the weeds for you. But the point is that it works. And then those HISPs that have been validated or accredited under the Rhode Island Quality Institute's program can share and allow exchange to occur between each other's subscribers. And literally hundreds, thousands of messages are now flowing under this regimen. The problem with this, and the folks at the Rhode Island Quality Institute would be the first to tell you this, is that not only do they have to run this, design this program, quasi-accredit the health information service providers in their state, but then they have to maintain that over time. And furthermore, it's not exactly the way Pennsylvania's doing it, nor Texas, nor the folks here in California. So one of the things that I would put to you is, do you really want to have multiple state or regional programs for the accreditation of these trust agents, or can we work together and make it a national program so that you don't have to bear the responsibility of maintaining these programs. And furthermore, the health internet service providers don't have to pay a fee to every state to do business in each state, which of course they don't want to do either. This should really work like the internet. It should be ubiquitous, it should be worry-free, and unlike the internet, it should be secure. So I'm going to turn it over to Sean at this point. He's going to talk to us about some really exciting things that are going on with respect to the patient's participation in Direct.